Today we are presenting on asthma, specifically focusing on the pathophysiology, treatment, and its relationship to the social determinants of health. Your presenters today are all second-year students at the UConn School of Pharmacy, including Carice Laura, Jack Mountain, and Amanda Idasui, and myself, Hannah McCarthy. Today, I'll start by talking about the pathophysiology of asthma, which is the result of chronic inflammation in the lungs. Individuals may develop asthma as a result of genetic predispositions, gene environment interactions, atopy or allergy, and individual patient specific factors. Chronic inflammation is the result of immune mediated inflammatory cells, including mast cells, eosinophils, T cell lymphocytes, macrophages, and neutrophils. People will present with clinical symptoms including breathlessness, wheezing, chest tightness, bronchoconstriction, airway hyperresponsiveness, airway edema, and mucus hypersecretion, which may eventually lead to the formation of mucus plugs.
All right, and now I'm going to talk about the risks and associated comorbid conditions with asthma. So what puts you at an increased risk for development of asthma? Well, family history does. There does seem to be a genetic component in the development of asthma, but there's other factors as well. And those include the development of a viral respiratory infection, or having allergies, or having exposures in your occupation, or to smoking, first or secondhand, air pollution, as well as obesity. And what are potential triggers to cause flare-ups or make the asthma condition worse? Well, this includes medical conditions like infections or acid reflux, conditions like that, as well as food and medications. And this can include NSAIDs or non-steroidal anti-inflammatory drugs, aspirin, pregnancy hormones, or food allergies. Smoke in any form, cigarette, wood burning, or leaf burning, for instance, can also be a major trigger for asthma. Weather changes, extreme weather, air pollution, and pollen, animal dander and saliva, pests, mold, exercise, and strong emotional responses. So this could include stress. Strong odor is also a potential trigger. So this would be things like perfumes, candles, and things like that. So now looking at different types of asthma. So asthma can be broken down in a couple different ways. These categories aren't necessarily mutually exclusive in the sense you can have different versions, multiple of these, for instance, but these are fairly relevant in the sense that they might affect your treatment and treatment goals, as well as what types of things you might avoid for triggers. So the first one I have listed here is adult onset asthma, and this one's relevant in the sense that it's pretty unique to have adult onset asthma when you look at relative prevalence of asthma, as the majority of asthma symptoms develop during childhood. And the next one, we have allergic asthma, and so this is characterized by the triggers that are involved with this type of asthma. So this is triggers related to allergens, so pollens, pet, and dust type of things. And then the next one I have listed is asthma and COPD overlap. So this is when you have asthma and chronic obstructive pulmonary disorder at the same time, and having both diseases requires both conditions to be treated and also special attention because both of those are diseases that affect the lungs. The next one I have listed is exercise-induced bronchoconstriction. So this one, another name for that is exercise-induced asthma. And like it sounds, it is essentially asthma conditions that occur with physical activity. Next one, non-allergic asthma, and this is triggers that are sort of outside of the allergic asthma category that I mentioned previously. So this might be from illness or medications or other environmental factors that aren't typically allergens. And the last one I have listed here on this slide is occupational asthma. So this is asthma symptoms as a result of working and you're getting exposed to different type of triggers at your workplace.
For prevalence, 1 in 13 people have asthma, meaning that more than 25 million Americans are affected. 7.7% of those affected are adults, and 8.4% of those affected are children, meaning that children are impacted at higher rates. Adult women are impacted more than adult men, but conversely, boys are affected more than girls. African Americans in the US are 3 times more likely to die from asthma than any other race or ethnicity, which is tied into the social determinants that Jack will discuss in following slides. Puerto Ricans experience asthma episodes more often than any other ethnic group. And in America, 10 people die each day from asthma, though most of these deaths are considered preventable with proper treatment.
All right. Like Hannah had mentioned, I'm going to talk a bit about the disparities associated with asthma prevalence as well as morbidity. So disparities seem to really span income levels, race, as well as geographic location. And disparities and prevalence are really thought to be brought on by the different types of exposures that low-income individuals tend to have. So looking specifically at disparities in asthma prevalence based on geographic location, you see that there are much greater rates of asthma within urban populations and specifically lower income African Americans. And this is thought to correlate with the higher amounts of environmental risk exposures that these populations tend to have. And this can come from housing conditions that are poor with greater amounts of dust mites and pests and animal dander, as well as other indoor biological contaminants, but also probably more so the pollution and air qualities from vehicle emissions within the urban setting. The degree of urbanization itself, or how much the city environment is a city, tends to be a great factor in determining the outdoor as well as indoor air quality. So looking at disparities based on race, Hannah had mentioned previously a little bit about some racial disparities, and just go into that a little bit more. African American children have the highest prevalence of asthma, uh, about 13.4% as compared to about 7.4% of white children. And African Americans in the US die from asthma at higher rates than people of other races or ethnicities. And so why might that be occurring? Well, in practice, there are larger populations of minority groups in these urban settings, as well as instances of lower income or general housing inequality that can result in these negative housing conditions. And another factor that could potentially impact the exposures or amount of exposures include environmental racism. And by that, I mean poor environmental factors affecting majority Black communities. And so I previously mentioned that there were greater amounts within the urban setting, but another study had found that looking at the rural setting specifically, there were great disparities based on income levels, where looking at rural areas, lower income individuals had higher prevalences and worse outlooks in terms of their asthma treatment. And this is thought to be from basically burning biomass for fuels and for cooking or heat. And this is incredibly relevant when you look at developing countries as well as within our own country, low-income rural areas. And the resulting burn-off and smoke that comes from burning these biomasses can be is at least thought of as the causative agent. So now looking upstream for treatments and future directions, what does that mean? So looking upstream refers to examining the causes of the disease and working on mitigation strategies to prevent them from happening. And so what factors are causing these higher rates? Where are they found? So this is, again, looking at, it can be within the rural setting, transitioning from biomass fuels to from those types of fuels and developing proper indoor ventilation or improving air quality in urban areas and improving housing conditions in those urban areas as well. If there's implementation of these prevention strategies and this reduction of these areas that might cause triggers or the development of asthma, you can not only save lives and save people the pain that comes with a chronic condition like this, but also healthcare dollars.
So, shifting into pharmacological and other healthcare interventions in the treatment of asthma, here's a quick overview of the most common methods of treatment. So, for non-pharmacological interventions, it would be avoiding asthma triggers, healthy diet, and routine exercise. And then there are also two categories of medications, including long-term control and acute relief. For long-term control, most popular is inhaled corticosteroids, best known to patients as Pulmicort, Flovent, and Qvar, and these work by blocking allergens and reducing airway sensitivity. This works to inhibit cytokine production and inflammatory cell migration, overall reducing bronchoinflammation. Inhaled long-acting beta agonists, such as Perforomist and Servant, agonize beta-2 adrenoreceptors and act as bronchodilators. Combination long-acting beta agonists and corticosteroids, such as Symbicort and Advair, have synergistic effects, which leads to anti-inflammatory and bronchodilator effects. And immunomodulators are newer treatment developments, including leukotriene modifiers, which are used as alternative therapies to low-dose inhaled corticoids. These include leukotriene receptor antagonists, which block the LTD4 receptor, such as montelukast, most commonly used. There's also 5-lipoxygenase inhibitors, which blocks the synthesis of all leukotrienes. Anti-IgE inhibitors block the binding of IgE to mast cells and basophils, which prevents mast cell degranulation and overall reduces inflammation. An example of this would be Xolair. For acute symptom relief, there are short-acting beta agonists such as ProAir and Ventolin and MaxAir. These are beta-2 adrenergic receptor agonists, which serve to relax bronchial smooth muscles and prevent immediate hypersensitivity reactions, including immunomodulators such as mast cells and other inflammatory response cells. These are known as rescue inhalers, and they can be used to treat sudden symptoms or prevent exercise-induced asthma. There are also long-acting muscarinic antagonists or anticholinergics. An example of this is Spiriva. These antagonize muscarinic receptors M1 to M5 and inhibit the M3 receptor, which leads to bronchial smooth muscle relaxation. This additionally reduces bronchorrhea, which is the excess watery mucus secretion. And combination anticholinergics and short-acting beta agonists, such as Comorbid, have synergistic activity in reducing acute symptoms. Some key reminders for patients that would be important for pharmacists and providers to keep in mind is the DIPS method of patient counseling. This includes dosing, whether a medication is scheduled use or is used as needed, instructions. There are two different kinds of inhalers. There's metered dose inhalers, or MDIs, which require patient coordination. Patients would need to press on the canister, inhale at the same, which may not be suitable for young children or other special patient populations. Conversely, dry powder inhalers, or DPIs, are more patient-friendly and do not require this coordination. Priming is also a notable point for pharmacists and providers and is required in all MDMIs. Uh, Priming is spraying the inhaler 2 to 4 times before using a new product or after a product is not used for an extended period. And special instructions, including breath actuated or capsule insertion methods for treatment.
So now I'll be touching on the treatment and counseling for adult onset asthma, which Jack said was symptoms of asthma developing as an adult. So treatment plans can include a combination of lifestyle changes and a range of medications. So lifestyle changes include smoking cessation, so cigarette smoke worsens symptoms. Medication treatment includes bronchodilators or corticosteroids. They're fast-acting bronchodilators, such as albuterol, work by relaxing the muscles of the airways, and inhalers that contain corticosteroids do not treat sudden symptoms. Instead, they decrease the frequency of the adult onset asthma symptoms. Counseling points to take into account: there are several things you can do to keep your asthma under control: taking all prescribed asthma medications as directed by your provider. Keeping an asthma action plan can help prepare you to treat asthma symptoms when they're happening. Each inhaler can work differently. Be sure to seek assistance from a healthcare professional to ensure that you're using them properly, like Hannah touched upon, MDI versus DPI. PDI. Avoid or limit exposure to things that make your symptoms worse, or identifying and avoiding your asthma triggers is essential in keeping symptoms under control. Now for exercise-induced bronchoconstriction, treatment includes short-acting inhaled beta-2 agonists, which are bronchodilators. They stop symptoms right away. They can take 15 to 30 minutes before vigorous exercise and generally prevent symptoms for 2 to 4 hours. Long-acting inhaled beta-2 agonists, also bronchodilators. These are to be taken 30 to 60 minutes before your exercise, and they help prevent symptoms for 10 to 12 hours. Montelukast is taken once daily. This is a medication that can help prevent symptoms that accompany exercise. Counseling includes warming up. Gentle exercise for 15 minutes helps before intense physical activity. Cover your mouth and nose with a scarf or face mask when you're exercising in the cold weather. And breathe through your nose while you exercise. Avoiding triggers by making changes to your exercise routine as well is helpful. Allergic asthma. Treatment and counseling for this includes long-term bronchodilators that relax the muscles in your airway. Corticosteroids reduce the mucus and the swelling. Anticholinergics prevent muscles from tightening. And the leukotriene modifiers prevent symptoms for 24 hours. Counseling for allergic asthma includes identifying your triggers and trying to avoid them, tracking your symptoms with an asthma diary, develop an allergic asthma action plan, and carrying quick-acting medications for temporary relief in emergency situations.
So I'll be talking about the treatment and counseling for non-allergic asthma or intrinsic asthma. So unlike people with extrinsic asthma, those with intrinsic asthma usually have a negative allergy skin test, so they won't often benefit from allergy shots or allergy medications. Medications for intrinsic asthma are used both to prevent an attack before it starts and to treat an attack that has already started. So some treatment options are long-term control medications like inhaler, nebulizers, short-acting rescue medications such as bronchodilators like albuterol. And some counseling tips are avoid sick individuals, limit excessive exercise, avoid very emotional or stressful situations, and stop the use of strong-smelling perfumes, vapors, or cleaning products. Treatment for asthma COPD overlap are the use of low-dose inhaled corticosteroids to treat ongoing inflammation in the airways, long-acting bronchodilators to keep the airways open for longer periods of time, long-acting muscarinic agonists that help keep the airway from tightening and stop the overproduction of mucus. Some counseling tips for this are respiratory illnesses can exacerbate, so a yearly flu shot is recommended. Lifestyle changes such as exercise, breathing techniques, and avoiding air pollutants in common spaces. And also it's recommended to see an allergist to help manage chronic conditions of asthma and COPD. Treatment and counseling for occupational asthma is as follows. So as we mentioned before, you can use inhaled corticosteroids, leukotriene modifiers, which would be an alternative to corticosteroids, long-acting beta agonists, inhalers, a LABA, and a corticosteroid. Counseling tips are to quit smoking if you haven't already, get your annual flu vaccine, avoid NSAIDs or non-steroidal anti-inflammatory drugs like ibuprofen, and maintain a healthy weight.
And lastly, I'll be discussing the impact of COVID-19 on people with existing asthma. So people with asthma are more susceptible to experiencing more severe side effects of COVID-19, which is also a respiratory illness. In some states, people with asthma currently qualify to receive the COVID-19 vaccine. There are some differences between symptoms of COVID-19 and asthma, which should be considered when a patient with asthma is concerned. So wheezing is common in asthma, but not COVID-19. Fever is also a common symptom of COVID-19, but not typically present in asthma. And again, headaches are rarely associated with asthma, but are very common in COVID-19. Asthmatic symptoms typically start and last for hours, while COVID symptoms are gradually onset and last for 7 to 25 days. The CDC recommends the following for people with existing asthma during the COVID-19 pandemic. To keep their asthma under control, they recommend the creation of an asthma action plan, as Chris touched upon earlier in the presentation. Asthma action plans can be created in coordination with your healthcare provider or pharmacist in order to ensure that your asthma is controlled in the following circumstances. 1, asthma is controlled and at baseline. 2, asthma is getting worse. And 3, medical alert or medical emergency. You should continue your medications unless instructed otherwise, and routinely clean and disinfect your space to avoid contamination with COVID-19. But you should also be sure that to avoid any cleaners that are known irritants or triggers. With any questions, please contact us. Our emails are on the screen here. But thank you for listening to our presentation. We hope you learned something. Thank you.